Hello, welcome back to Beyond the Bedside podcast, your go-to show for feeling inspired and connected to the nursing community. I'm your host Isabel, and in today's episode we're going to explore a widely studied case study. Based on that statement, can you guys guess what it's about? Well, I'll try not to give it away, but I can give you a hint. This case study demonstrates the importance of identifying specific principles when caring for a deteriorating postoperative patient, as well as highlighting major events related to crisis resource management. We all know that patient outcomes are highly dependent on the collaboration of team efforts from interprofessional and interdisciplinary dominance, right? Well, our experts Harriet, Shannon, and Hannah are going to share some insightful information to help us recognize areas of challenge and determine what is the best evidence-based recommendation for this following scenario. Thanks for tuning in. Let's dive right in. Case study. Sally is a 68-year-old female who was admitted to the emergency department following an unwitnessed fall resulting in a suspected left hip fracture. Despite initial pain management attempts, she required an emergency surgery. Surgery was reported uneventful. Postoperatively, her recovery commenced on a ward and appeared stable with nil initial concerns except pain management. Yet postoperatively, day 2, Sally's condition dramatically declined. How could this happen, you may ask? Sally continued to show signs of worsening pain, lightheadedness, raising possible assumptions of sepsis. With this prompt, it was alarming that her condition was not promptly reviewed. Furthermore, later in the evening, Sally reported severe pain and deteriorated significantly, which was understated by the nursing staff. Despite several attempts to escalate the care, her condition rapidly got worse. She was found unresponsive and transferred to ICU for further monitoring. Despite the aggressive treatment, she was sadly died the following day. Now, Harriet, what do you think happened here?
Thank you, Isabel. So I wanted to specifically talk about the crisis management resource and analyse the clear failures to adhere to this resource from the staff in this scenario. I think it's important to outline the clear warning signs were not escalated. Day 2 at 8:40, Sally had complained of feeling funny and was having 9 out of 10 pain score. While nursing staff administered subcutaneous morphine, there seems to be a real delay in a medical review and further exploration of why she's experiencing such severe pain. In relation to the CRM, situational awareness was not occurring as deterioration was not adequately escalated or explored. Sally's deterioration is clearly documented, but communication for a medical review was not had. During day 2, when the nurse contacted the surgical team, but the phone went to voicemail, other routes of communication should have been explored. Finding different escalation pathways and using assertive communication to stress the importance of the situation could have stopped Sally from further deteriorating. Timely involvement from the ICU or surgical team could have also stopped Sally's deterioration. This shows a clear delay in escalation of care. I also want to touch on how there was no indication of a multidisciplinary team, huddle, or communication trail to escalate the concerns of Sally's situation. Circling back to the CRM, this showcases ineffective communication pathways in regards to persisting pain despite regular analgesia. I also found it interesting that on day 2, notes from 3 o'clock showcases Sally experiencing 4 to 5 out of 10 pain. However, she deteriorates very quickly at 8:40. I think this suggests that the handover really lacked depth about Sally and her trends in the QADS and pain scoring. In regards to the CRM, I think this clearly indicates the gaps in handover. Now, one part of the CRM I find really interesting is cognitive fixation. There isn't any documentation of a further full pain assessment or any other assessments or tests to consider alternative diagnoses until later on. I think it is clear that the team, in this case, were fixated on treating the pain rather than asking why is this still occurring. Circling back to day 2 in the afternoon, the nurse should have then started the sepsis pathway, but clearly was fixated on Sally's pain. I want to pass over to Shannon, where she'll outline recommendations on how Sally's situation could have been prevented.
Thank you, Harriet. Moving on to some evidence-based recommendations that I think could have made a real difference in Sally's care. To start, structured communication. We all know that clear and consistent handovers are essential. Using tools like ISPA saves lives. In Sally's case, earlier escalation using structured communication could have prompted a timelier clinical review. Structured communication improves decision-making and team collaboration in high-pressure settings like post-op recovery. This communication could also have helped the overloaded nurse caring for Sally and 5 other post-op patients. Next up, early sepsis and deterioration recognition. Sally has textbook warning signs, increasing pain, lightheadedness, tachypnea, a fever, and confusion, but these were missed or downplayed. Computerized clinical decision support systems such as QADS or early warning scores can flag potential deterioration cases early, prompting faster intervention. This is important because every hour delay in antibiotics increases the risk of mortality. Then there's the importance of rapid response systems. Sally's nurse voiced concerns early on, but it took several hours and multiple calls for the surgical team to respond. Evidence shows that having a tiered rapid response system where staff can escalate even without a full MET call improves early intervention, especially in rural and resource-limited settings like Sally's. If you're concerned about your patient, don't be scared to initiate a MET call. And finally, timely documentation. Vitals were taken but not documented immediately. This delay meant important trends like deteriorating oxygen saturation and delayed cap refill weren't acted on soon enough. Good documentation is more than just record keeping. It's a clinical safety tool. So please, listeners, never wait until the end of your shift to begin documentation and ensure vitals are documented promptly. When we bring all this together, the structured communication, the early recognition, using escalation protocols, and sharing the workload, what we're really doing is creating a safer and more responsive system so patients like Sally don't fall through the cracks. Anyway, that's all from me. I'm going to hand the mic over to Hannah now. Thank you for listening.
To summarise, this case powerfully highlights how failure to apply CRM principles like communication, situational awareness and escalation pathways, as well as how evidence-based practices directly contributed to Sally's fatal outcome. Drawing on what Harriet discussed, Sally's worsening condition was documented but not yet acted upon. Staff appeared focused on managing her pain without exploring the underlying cause, showing cognitive fixation and lack of critical clinical reasoning. Communication failures further compromised the issue. For instance, when the nurse contacted the surgical team and received no response, no alternate escalation methods were pursued, allowing Sally's condition to worsen. These are just three of many CRM principles that weren't adhered to for Sally. Shannon's discussion of evidence-based strategies highlighted key improvements that could have changed the outcome. Structured communication tools such as ISBAR support clear, effective handovers and decision-making. Early use of rapid response systems can trigger timely medical intervention, and accurate, up-to-date documentation is vital in recognizing and responding to patient deterioration. This case emphasizes that CRM principles are not only optional, they are critical to patient safety. Sally's outcome may have been different had these principles and evidence-based recommendations been applied. Ultimately, us as nurses, it is our responsibility to advocate, escalate, and act decisively to protect our patients. That's all from us. Thanks for listening to our podcast.